On behalf of HealthCert Education, I'd like to welcome you to this evening's webinar. This is the 6th webinar in the series aimed at bringing value to our alumni by providing clinical guideline updates and new information for you to easily and concisely with a wonderful presenter who shares relatable and interesting cases. We've been very impressed by the number of people registering for these webinars, and so we'll continue to offer them as part of our value-added content offering. Now, this webinar focuses on updates for what's new in cervical screening, a quick reference guide for primary care health professionals. Now, before we get started, I'll run through some housekeeping and introductions. So at the end of the webinar, we have a post-webinar survey that provides you with the opportunity to give feedback on the webinar and request some more information on any of our courses that might help you in your CPD journey or to subspecialize in particular areas of interest for your practice. And for those of you attending live or watching the recording, you may be able to apply for CPD for this webinar. And so a certificate of attendance will be emailed out along with the recording with some instructions on how to self-submit to your relevant college for consideration of CPD. And with that, let me make a proper introduction to Dr. Simone Gonzo. Dr. Gonzo began working in healthcare as a registered nurse in hospitals throughout Queensland in 2003, and after making the change to medicine, she graduated from the University of Queensland in 2010. Dr. Gonzo enjoys all aspects of general practice, including family health, mental health, chronic disease management, and complex primary care. She also has a special interest in teaching and training GP registrars and medical students, and she's currently working on a Master of Healthcare Leadership. And with that, I'll invite Dr. Simone to get the presentation underway. Over to you.
Thanks very much, Campbell, for that wonderful introduction. I'd also like to thank HealthCert for having us tonight to talk about cervical screening and the new updates as of July 2025, or a little bit earlier, but that's when we've been able to collate all the information together. So we'll start with our usual acknowledgement of country. Acknowledging the Gubbi people where I am in northern Brisbane as traditional custodians of the land, recognising their continuing connection to the land, waterways and community, to elders past, present and emerging. I also have a little bit of a biography slide there about, yes, being in private practice. I work in Caboolture, right through to doing some further study into healthcare leadership. So this evening, what we'll be looking at is the cervical screening guidelines update as of 2025. This is the most recent version of the update over the past few years. We'll then be looking at a couple of case studies over the lifespan just to see how we can reflect back and use the new guidelines with our new information. So these guidelines were updated to reflect best clinical practice. The big focus is on the change with self-collection and the follow-up changes. So self-collection has been broadened to different populations. The follow-up changes have then reflected what we now know in terms of being able to follow changes up of early changes that we can just change the timeframes of that follow-up. There's also been a couple of changes of test of cure and HCIL and adenocarcinoma in situ, also post-hysterectomy, and the immunodeficiencies and how we treat them and look at them and define them actually has been more clearly articulated. These particular guidelines, or this version, is effective from April 2025. So not a lot of big changes, but just a few things to be aware of. So it's probably more of a lighter refresh in terms of guidelines. The resources that are available are with the Cancer Council. So this is the actual document. It's 312 pages long, and it's put out by the National Cervical Screening Program as part of the government's cancer screening. Also on that previous slide, the National Cancer Screening Register websites. So with our PRODA connection and in our best practice software, we'll talk about as we move through the webinar using the National Cancer Screening Register and how that links in with all of our cancer screening and how that manages this as well, and how it can be a good resource for us in terms of deciding whether a patient is due to have their cervical screen now or at what time frame. So we'll move through and look at this very busy slide, which is basically the overview flowchart for the routine cervical screening, and that's the main ages 25 to 69. So you can see there's a few patterns. So moving from left to right, our left is green, so that's our low risk patients. And then we move into the yellow, which is intermediate, and then the red is higher risk. So basically what the guidelines are showing us is that when we talk about a HPV test at the top here, that is assumed to be or can be assumed to be a self-collect test. If we have detected something, if we move to the orange one, so we've detected something, we're wanting to do a liquid-based cytology, and the lab can do that, or we call the patient back to be able to do that. So that's where we start up here, assuming we're all doing a self-collect. That's our starting point, and then we move through all of the different algorithms and flowcharts depending on where the patient sits. So the changes or the updates to the National Screening Program have been collated into some very comprehensive or even basic charts for us. So this one is from some of the pathologists, and each pathologist has put out their own document to sort of summarize this to make it easier, like a bit of a cheat sheet, which, as we all know, can be very handy when the patient says, am I due for my cervical screen? Am I due for my pap smear? I'm sure some of the patients still call it a pap smear. So this is one side of the flowchart that I've just screenshotted, and you can see that it starts with the treatment for HSIL down in the bottom right. So we're looking at a patient who's been diagnosed with high-grade squamous carcinoma, and that's where we go into the green, the orange, and the red being higher risk. So HPV is not detected. We repeat in 12 months. It's not detected again. Therefore, we've completed our test of cure, moving back to our routine 5-yearly screening. So all of these flowcharts can be applied to a patient's particular situation. We have the screening of people with immune deficiencies. So as I've already explained, this category has been clarified and expanded. We don't have to write any information on the request forms apart from just writing immunodeficient. As I'm sure most of you will know, if you do a CST too soon in between the timeframes that is expected, the patient may get a bill in the mail from the pathologist unless we annotate on the request form why we're doing that. So that's why we write immunodeficient, or we may write that the patient's having some symptoms. So that's why that testing period has been shortened. And obviously those patients will be referred for a colposcopy if any type of HPV is detected. These people with immunodeficiencies now are looking at a 3-yearly screen rather than a 5-yearly screen. So it's recommended that patients living with HIV, organ transplants, hematological malignancies, stem cell transplants, and primary immunodeficiencies, they're recommended to have their 3-yearly screen. Highly considered are the patients in the right side of that column. So they're the long-term treatment with highly immunosuppressive therapy, so high-dose corticosteroids, DMARDs, biologicals, multiple immunosuppressants. They may choose to have a 3-yearly screen rather than a 5-yearly screen. So on the flip side of this card that has summarized it, we have screening after total hysterectomy. So this has now been simplified to annual testing. So if the patient has had a hysterectomy and the screening history shows no evidence of any high-grade squamous carcinoma or adenocarcinoma in situ, they move down through to end up at no follow-up. So if the patient has had hysterectomy and the extreme side of that is an AIS, regardless of the findings, those patients will be recommended to have annual co-tests, so yearly co-tests, which is your clinician-collected co-test, until 2 consecutive negative co-tests. Now, the surveillance with that also following the excisional treatment of adenocarcinoma is also been summarized on that cheat sheet. So that gives us a scenario where the patient has had, hopefully we'll be seeing them at the complete excision stage. The gynecologist hopefully will have them over here at the incomplete excision stage and be following them through until they can hand them back over to us for follow-up for their complete excision. Those patients have annual co-testing, and any abnormal result gets referred for colposcopy. Looking at the more simple aspect or the simple situation of a patient who doesn't return after their self-collection at 9 months. So this patient has done a self-collect and they've detected a HPV, which is not 16/18, and the patient has not returned for the clinician-collected liquid-based cytology within 6 weeks. That patient can now be offered a self-collected HPV test rather than the liquid-based cytology. So that determines if the HPV infection has cleared and the patient can return to routine screening. Obviously, if we have the HPV not 16/18 detected, the patient is sent off for further testing as well. So the changes in terms of self-collection and follow-up changes, when the HPV not 16/18 has been detected via self-collect, that patient can now have follow-up with another self-collected test in 12 months' time. Previously, it required a co-test. So the idea is that we're supporting more patient participation and flexibility. So the interesting thing there is that it has increased the uptake of these tests, and patients are more likely to ask about are they due for their follow-up when they are more open to the idea of doing a self-collect test. The test of cure and HSIL. So post-treatment HSIL follow-up now uses an annual HPV test instead of the co-test. So that can be a self-collect test for their annual HPV test instead of that. So the patients can do that themselves at home and then just drop it into the pathology. It can be a clinician-collected sample. So if you're doing an examination or something like that and the patient says, well, it's due, why don't we just do it? Yep, you can do it. We no longer need that cytology test for a test of cure. Individuals with persistent HPV on 3 consecutive annual tests, they need to be referred for colposcopy. So that's 3 consecutive annual testing. They get referred off to the gynecologist. It also applies retrospectively, so it doesn't really start from now. So this is where the National Cancer Screening Register will come into play and inform our clinical decisions, is that it's kind of been reset, or the new guidelines have been applied to that. So you may find that some patients, their follow-up or their recalls that you have put in as their primary clinician into your software may not align with what the NCSR says, and that's because they may have already been returned to a routine 5-year screening on the NCSR because that's collected the data and adjusted accordingly. Now, the laboratories are to charge as a test of cure to prevent patient cost impact during this transition. So that's where the notation on the actual request form becomes really important in terms of cost to the patient. So that's always helpful if you can, offer them something that's bulk billed rather than them get a bill in the mail later on down the track. So if we look at some more specific cases, we've got our treatment for HSIL. So that's the old SIN2/3. And what we're looking at there is we've done a self-screen, detected a HSIL. HPV test is commencing at 12 months post-treatment. So that can be a self-collect test post their treatment for their HSIL. Patients then are in the green, so they're not detected. They just follow up, repeat that HPV test at 12 months. Once again, not detected. They've completed their test of cure, moving back to routine 5-yearly screening. Patients, however, that's nice and simple on the green side of things. Patients who have still detected the not 16-18, we then have to do a reflex or co-test, and then see what, depending on what that result is, they get followed up with HPV tests every 12 months until they either move into HPV not detected, or we get upgraded and detect then a 16-18 or not 16. Then they get referred off to the gynecology or for colposcopy. And you can see how once you get used to using these flow charts, the terminology and the colors make it quite easy, so you can sort of visualize where the patients are sitting in that area. So adenocarcinoma in situ, so annual co-testing. Once the patient has had their treatment for their AIS, they're under annual co-testing with referral for colposcopy for any abnormal result. So that's the co-test clinician collected. After 5 years of annual negative co-tests, they can move to a 3-yearly test. And then after 25 years of negative testing, individuals less than 70 can then return to routine 5-yearly screening. So obviously it's a long follow-up for those patients that have had AIS. And just a mention there that while those 70 or older can exit the program and the program ends at 70, it's often a good idea to still recommend to patients that even though the screening program ends at 70, they can still continue on with cervical screening if they feel the need to. So they won't get charged if we still stick to that 5-yearly self-test or clinician collect, whatever the case may be. But the patients can still have their CSTs if they require that, if they prefer. So following up after excisional treatment for AIS, we want to make sure that the patient has had complete excision. If the excision has been incomplete, they're obviously going to still be under further gynecological treatment for a further excision. They still sit here with their annual co-test, which you can quite easily sort of transpose over here. So this generally is where the patients would finish with gynecology treatment or input. They would then probably be handed over to us here. So we've gone for, or we've achieved a complete excision. Patients then will be having their annual co-test. Any abnormal result, straight back to gynecology for colposcopy so that we can make sure that adenocarcinoma has not recurred. Now, post-hysterectomy, depending on what the hysterectomy was performed for in the first place, the annual HPV testing is required until we have 2 negatives, annual co-tests for AIS until we have 2 negatives, so 2 years of co-tests. After 5 years of negative co-tests, post-AIS, we can then move off to 3-yearly. Once again, it sounds very complicated and wordy, but once we start to get familiar with the flow charts and seeing which situation applies to which patient, you can easily source the answers for those patients. So on this particular one, we've got our screening after the hysterectomy. Depending on what was happening prior to the hysterectomy, AIS, HSIL, never screened or unknown screening, we end up then following these flowcharts through to either the annual co-tests until 2 consecutive negative co-tests, right down through to having no follow-up required at all. So that just makes it easier to work out. Immunodeficient patients. So this is a cohort of patients that are recommended to have 3-yearly screening rather than the 5-yearly screening. It's recommended for those patients living with HIV, solid organ transplants, active hematological malignancies, primary immunodeficiency stem cell transplants, and highly considered in patients with hemodialysis, immunosuppressive therapy such as high-dose corticosteroids, DMARDs, and there are other biologicals and immunosuppressants. These patients, and there's surprisingly probably a fair few in the community now, if you start to think about who's on steroids and the DMARDs that we're using for different things, those patients have their screening at 3 yearly. And then if we detect any type of HPV, they're straight off for a colposcopy. The anogenital tract should be, because they're immunosuppressed, should be assessed. And then we work out where they're sitting in terms of HSIL for excisional treatment, adenocarcinoma in situ, and their follow-up is generally based on those findings. And even if once they're finished with their treatment and for that particular abnormality that was found, those patients would be on the 3 yearly testing for the length of time that they're on that medication or having that treatment. So it all sounds very complicated and very busy, but we'll work through a few different case studies just so that we can have a look at it and also just look at some resources as well to make this a little bit less overwhelming. You don't have to, obviously, you don't have to be able to remember every single situation for every single patient, but so long as you know where it is, the information to find out, to double check sometimes, is that right? Or, did I calculate that correctly? These case studies will help talk us through that or walk us through that. So our first case study is Jane. She's 37 years old, busy working. She's actually overdue for screening. She's got the reminders or has moved around and hasn't really paid much attention to it. Prefers not to have a speculum exam. When she's offered the self-collect as an option, jumps at the idea, thinks that's really great. So she returns her CST self-screen and she comes back as a HPV not 1618 detected. So working through her situation, she has no symptoms. It's just purely screening that we're deciding to catch up with. So we've detected a not 1618. So she has been recalled to come back for her LBC, so her co-test. And that would be the plan for her. Depending on what we find on that, she either gets a repeat. If it's negative, she gets a follow-up HPV test in 12 months to see whether that HPV not 1618 is still there or not. If we do detect something, she's off for a colposcopic assessment. So that's the plan that we have for Jane. However, we haven't been able to contact Jane for 9 months or more than 9 months. So under the new guidelines, she could be offered a new self-collect test instead of the co-test. So enough time has passed, the rationale is enough time has passed to basically reset that to see whether or not the HPV is still persisting. And you can see over on the right side of the slide there that we've got directly from the guidelines repeating the self-collect at 9 months for patients who don't return for their liquid-based cytology. That makes things a little bit more manageable and less overwhelming for a patient, and also easier for the patient to be able to access this screening. So she ends up repeating her self-collect, and we've ended up with a HPV not detected on her second screen. So she therefore returns to her 5-yearly screening pathway. So the HPV infection has cleared itself. Now, with this example of Jane, we'll work through our clinical tip just so that we can demonstrate the National Cancer Screening Register portal, how we would use it with a patient. So I've tried to screenshot, depending on what you're using, primary care software. The NCSR has been integrated with Best Practice Medical Director and Communicare. On Best Practice, it looks or it appears like this on the screen. So if you move up to, I think it's under View or maybe under Utilities, if you scroll down there, you'll get to the NCSR hub. This is our test patient, so it has no Medicare patient. So I've just screenshotted that you can see we're in the actual best practice patient chart. So that links directly in to View or Utilities. I can't recall which one will throw up this window. but you'll come down to the NCSR hub. If you click on the NCSR hub, because it doesn't have a Medicare card, it won't link to that. If you click on that, it will show you when the patient is due for their CST. It will give you their last screening of their CST, when it was due, their last results. So you'll probably find that you use that a little bit more when you're trying to work out if a patient is due or not, depending on their last result. So because that actual link, the National Cancer Screening Register, is updated directly from the laboratories. So the laboratories feed their data directly into that. If you're not sure on the patient's last result, that's a way of accessing that so that you can see what their last result was, and you can import that directly into best practice anyway as an investigation. So that's just another good way to double check where the patient is in their cervical screening and how that's going to work for them. A legitimate patient, this screen would be showing us the patient's CST history as well as their bowel screening history at this stage anyway. So if we move through to our next patient, we're going to be chatting to Catherine. So Catherine, she is 42 years old, and her routine cervical screening via self-collect has detected a HPV 18 positive. So with Catherine, she's been recalled for a clinician collect, and the co-test has also showed that she has HPV 18 positive, and the cytology suggests there's a glandular abnormality there as well. So where we go from here with Catherine is she is referred for colposcopy directly. Colposcopy finds that there is no visible lesion. So the gynecologists have done their colposcopy. There's no visible lesion there. Endocervical sampling, however, and biopsy confirm she's had an adenocarcinoma in situ. So when we look at where this is putting Catherine and her treatment options, she is now been diagnosed with adenocarcinoma in situ, or AIS. So the diagnosis is explained, treatment options discussed with patient, looking for shared decision-making. She initially elects for fertility sparing treatment to start off with. So Catherine has a loop electrosurgical excision procedure, or a LEEP, with clear margins. So after that, she then discusses with the gynecologist recurrence risk and ongoing screening. Because we've now had her surgical excision, the surveillance following that is annual co-testing. If there is any abnormality, she's sitting down here, she has annual co-testing. If there's any abnormal result at all, she's referred back for colposcopic assessment. Now that happens for the intervals extended to 3 years if all co-tests are negative for 5 years. So annual co-test for 5 years. If she's negative in that time, she then gets extended out to the 3 years. If all the tests are negative for 25 years, so that's the 5 years annually, then 3 years, 3 years, 3 years, she can then return to her routine screening if under 70, or exit the program if over 17. So Catherine goes away and has a think about her options and what she wants to do, and life rolls on. Due to the AIS multifocal potential, she then proceeds with a total hysterectomy 12 months later. So she figures that she wants to reduce her risk of recurrence, has a total hysterectomy. The histology then confirms AIS, which has now been completely excised, and there's no residual high-grade lesions. So we then provide her with some counselling, or the gynecologist should provide her with some counselling on the long-term follow-up requirements. So with Catherine, she has now had her hysterectomy. As she had her AIS removed, she's up here in the right-hand corner Regardless of findings, she ends up with annual co-testing until 2 consecutive negative co-tests, and then she doesn't need any further testing. So that's where she's had a hysterectomy after an AIS. So, and the AIS has been cleared on that pathology that's come through from her surgical procedure, having her annual co-testing until 2 consecutive negative co-tests. So that is the end of our case studies. And just to summarize the module, I just wanted to have a bit of a brief discussion in terms of just checking or highlighting that the NCSR prompts in the GP software. So in best practice, they come up as a little red reminder on the top. You'll probably find that they become more and more important because that's planned to be the register for the mammogram information, cervical screening, and bowel cancer screening information. So that should now be much more up to date and accurate. In terms of the flowcharts that were presented in tonight's webinar, this is where you can find them, Cancer Council or cancer.org.au, and you can download that and just have that PDF there if you need to refer back to them. There's quite a few pages of them. We've just selected a few tonight to have a brief look at them. And if in doubt, always refer to your local gynecologist, or if you think the patient still is at risk, refer them anyway to the gynecologist, and the gynecology department will soon tell you whether or not that patient needs their colposcopy or whether or not they need to have another co-test or further treatment in the next 12 months or so. So the references that we've used, or that document, can be found here by the Cancer Council. So that will hopefully give everybody a little bit more information and just a brief overview on where things are sitting in terms of the self-collect guidelines, where we are with that, and the impact that it's having in terms of cervical screening within the community. So I think that wraps us up for tonight, Campbell. It's a bit of a shorter, briefer version and cover of the guidelines, but I'm more than happy to answer any questions and have a chat on if anyone has any issues there or concerns.
Wonderful. Well, thank you, Simone, for that insightful presentation. Certainly covered a lot around there. So let's move on to some Q&A. We've received a couple of questions in there already. Now, Danielle writes, when no further required for a patient, will the NCSR state no further screening required, or will we need to look at results and work it out each time? I'm in community, so I might not be the primary clinician.
I'm really much more familiar with best practice. So you'll find that they just, when it comes up, they won't have, you can go to the NCSR and it just will say that screening is complete. And you'll also find that at the top of our reminders window, it won't have that red flag or red NCSR that says, CST overdue or due to be done. So yeah, it will basically say that the screening is complete, which can be a bit of a trap for patients that are 70 because they may want to continue on with their screening. So it's always good to just, be open with the patients and say, I can see here that you're not needing to have it, or it's not as part of the guidelines. However, if you want to, you can still take up the opportunity to have your screening ongoing.
Excellent. Thank you for that. Now we have another question here. Sometimes I get some patients yearly screening, but it is a month earlier because they get a recall by mail 1 to 2 months earlier. Is that free of charge if I get it done 1 to 2 months earlier?
Yeah, that has been a bit of a problem with some of those letters and the way that they've actually changed the NCSR. The patients have been receiving those letters basically too early. So they've been turning up to their general practitioner with the letters. The GP says, oh, it must be time, we'll do it. But it actually is too early, and the patients have had bills in the mail for that. So I would actually then just double check. It's not so much of an issue now because it seems like the system has worked out its bugs. For a while there, it was worth just double checking and saying, yeah, look, you're not due for another 3 months. I'd hold off for 3 months. Otherwise, there is the potential of you getting, I think it's a $36 bill to have that done, and the patient saying, yeah, not a problem. And we can always adjust our reminders and recalls because on my recall system, when I get the patients, so I've got the patient's result for their CST today, I always change my recall to say, yep, that patient is now due for 5 years. So I always add it up and go, well, you've got this letter that says that you're due. However, on my recall system, you're not due for another 3 months. And because it's a screening program, 3 months is not going to make a big difference. And it's probably going to save them the $36 as well. So yeah, I'd probably just watch that, but it doesn't seem to be so much of a problem now.
Excellent, great advice. Thank you for that. We have some questions, and Danielle, our first question, said to say thank you. Good point regarding the 70 plus cohort. We have a question here. I would like to ask about the guidelines for HPV vaccinated person.
This is the guidelines for everybody. So anybody, this is the Australian guidelines, where regardless of whether they have had HPV vaccines or not, applies to everybody. How the HPV vaccine is impacting on our cervical cancer is that because we can actually test for the HPV, it gives, or the virus, that's what we're testing for. We're no longer in the old cervical screen. We were testing for cancer cells. So that was giving us less time, if you like. Whereas now, because our initial testing point is HPV, we've got such a long lead time between detecting HPV and cancer developing. So because we have such a large population, or a growing population of patients that are HPV vaccinated, we're just going to carry on with looking or detecting HPV, and we'll find that the intervals that we'll be testing will get longer and longer, and we'll actually end up, the plan is that we eradicate cervical cancer anyway. But these guidelines, coming back to the initial question, these guidelines are for everybody, regardless of whether they've been vaccinated or not. But that's the rationale behind it.
Okay, great. Now, Sathika has a couple of follow-on questions, but I'll just try and summarize. Sometimes patient can present with symptoms before the due date for CST. So if we do a CST, has the patient got to pay?
No, they don't have to pay. And that's where you'll find on your pathology paperwork, it says basic screening, or is the patient symptomatic? So if you do a CST and the patient is having some abnormal bleeding or discharge or any other symptoms, the game changes, and it's no longer a screening program. It now becomes a diagnosis. So it's a diagnostic test rather than a screening. So no, they won't have to pay for that.
Excellent. And a follow-up question from Sathika. Any patient who has positive CST, do you recommend Gardasil vaccination?
Um, it's probably, the horse is probably bolted by then. The patient would then have to pay for their Gardasil because they've missed the free government funding for that. So the patient would have to probably pay, and it's probably not really worth it. The patient cohort that would be worthwhile considering having their Gardasil or their HPV vaccine, if they haven't had it during their normal like government funded vaccination program, are those patients that are immunocompromised. So for immunocompromised patients, if they are in their 30s, 40s, and they haven't had a HPV vaccine, it's probably worthwhile considering that. And I just can't recall now whether that would be funded or not. I seem to recall a patient that I think she did have to pay for hers. But they're the patients, immunocompromised who have never had any CST. That would be a good cohort to consider having that discussion.
Okay, great. A question from Jamila. Do you have any tips for addressing the medico-legal risk of turning an early patient away who doesn't want to pay and then they don't attend after 3 months?
If they're doing their CST, I always give them the kit, because you can take that home with them anyway. So that's medico-legally, all you're doing is giving them the option. You're not declining them the test. So to clarify, we would be saying, yep, sure, not a problem. You've got your letter. It's a little bit early. What we'll do is we'll give you the self-collect kit, which most of you probably know. It's just the little swab kit, similar to a wound swab kit, and label it up, give it all the pathology on there. And what I've done is I've actually written the date. So for example, if they turn up today, I'd be saying, okay, so I'm going to write in here, big highlighter pen, 21st of September, for example, 2025. After that date, you can go and have your cervical screen. If you don't trust yourself, and you'll still get your reminder from me as a GP, because that's already set. So in September, you'll be getting that buzz to your phone to say, go and have your CST. So if they are not symptomatic and it's routine screening, so long as you give them the kit at the time, I know it's hard to get into GPs and people might be traveling, you've given them the kit, it's then up to them to be able to follow that through. If you have declined it and they're symptomatic, that's a whole different story. But if it's basic screening and they'll get a reminder, they've got the kit, they'll get a reminder still from the GP, because that's how I've set up my system. They'll also get another reminder from the National Cancer Screening Register as well. So we should be covered by all bases there. But I think medico-legally, the risk would be very low if you followed those steps.
Okay, great. Still have a couple of questions. So Joanne asks, and we were talking about this a little bit prior to the webinar tonight, how much can we rely on self-collection sample?
It is proven to be just as good as a clinician collect sample, which is scary if you think about it, because it means that a patient doing a CST sample, provided you give them the right education and the little pamphlet that demonstrates how to do it, and it is quite basic, quite simple. So it is just as accurate as a GP collecting the same sample. So obviously it's not the same as a co-test, because a co-test has got your HPV as well as the liquid-based cytology. So that's basically a different test. But for a HPV self-collect, it's as accurate as a GP doing it, or a clinician doing it.
Wonderful. And there was just to follow on from that, there was that pre-asked question that was just regarding latest statistics regarding the uptake of self-testing. Is there any data that you can speak to about that?
That's been interesting in researching for the actual webinar, because there is actually a lot of different data, and it's also dependent on the time frame that it was taken over. So, for example, any data that was collected to the end of last year, so to December 2024, will tell you a specific percentage of uptake. But what is clear in the figures is that the more we go, so from December compared to, say, March 2025, the overall uptake has increased in every cohort, and is increasing in every cohort. And I think some of those figures, even in terms of like rural and remote communities, Aboriginal Torres Strait Islanders, and LGBTQ alternative communities, they are having the most increase, up to 45% increase in cervical screening that we're seeing in some communities. And there is also some anticipation, or some talk that if the cervical screening becomes like the bowel screening, where the kit gets sent directly to the patient, that will increase even more. So a lot of you are probably familiar with the bowel screening test, which completely bypasses the GP in terms of the patient turns 50, gets their big envelope in the mail. That's their bowel screening. The GP, all the GP has to do with that whole interaction, I suppose, is they get the result to say that the patient has had their bowel screen and it's negative or positive and needs to be followed up. If the cervical screen follows suit and that ends up being posted out directly to the patient, the uptake will be even higher. So we're hoping that that will follow through with the overall goal, I think, especially from Professor Ian Fraser, of eliminating cervical cancer within Australia, that we're going to head fairly close to that with the increase in screening and the HPV vaccine as well.
Wonderful. Well, thank you so much for that response. And that brings us to the conclusion of this evening's webinar. A big thank you to Dr. Simone Gonzo for taking time out of your busy schedule to share your expertise. Thank you to everyone for joining us, and we hope to see you at the next webinar. Have a wonderful evening.
Great. Thanks, Campbell. Bye now.